Hi, I'm Dr. Hakim, consultant orthodontist, diplomat in the American Board of Orthodontics, practicing here in Dubai. And today, what time is it? We want on-time orthodontics. You must have heard about early orthodontics, but you've never heard late orthodontics. So today we're going to answer this question. When is the right time for orthodontics? See you. So welcome back. Again, I'm joined by my colleagues, Dr. Anna and Dr. Omar. And today we're going to address this very important question, is when is the right time for orthodontics? And that's why we use the term on-time orthodontics. Because if it's early, just like we don't want to pay our bills early, we don't want to arrive too early to a party, so we'd always like to be on time. So for me, the naming of early orthodontics is actually a misnomer. It's incorrect. And for late, well, I have patients in their 70s, and their orthodontic treatment timing is just perfect for them. So what we're going to discuss today is on-time orthodontics. So to move on, it's very important, and it's often asked for children, when is the right time to start orthodontic treatment? So to answer this, there are three justifications. If any one of those three justifications is present, then the timing is now. And what are those justifications? Number one is psychosocial, meaning behavioral, child is concerned about the appearance, etc. Number two is if the position of the teeth increase the risk of damage due to trauma. We know that adult-sized teeth emerge at around the age of 6 to 7 in children, and with the child's face, sometimes they could seem out of place. If the teeth are in a position that increases risk of damage due to trauma, then obviously we need to protect those teeth, because these teeth are not to last for a few years, they're to last a lifetime. And finally, if there's anything affecting normal growth and development, things like habits, things like unfavorable muscular activity, or even unfavorable breathing patterns. So to get right into it, first, let's hand over to Dr. Omar, and please tell us about your experience with orthodontics.
Okay, so I think the 3 points you've mentioned, first of all, those are what we look at, 3 valid points. We need to be there on time as to give the patients either a more comfortable life experience and to tackle any malocclusion that's there. And speaking on your first point that you mentioned, psychosocial. I think if we refer back to the first episode that we've had, I've told you one of my most memorable experience is the young kid, 8-year-old, who walked in with his mom, traumatized. He cannot smile. He doesn't want to smile because he's getting bullied at school. Not joining friends during activities, not going to lunches at the lunch cafeteria fairs, and not want to be involved in any sort of events that happen. And if a kid at 8 years of age, you see, misses all that, how does that affect them growing up? How does that affect their confidence as an adult later on with prospects, meetings, whether it's job related, partner related, it all carries on later on in life. The journey that I had with him, we managed within 6 months, all that jumbled front teeth that really didn't give the kid the confidence to smile. We aligned it, got it nice in a safe position. Kid now walks happy. He comes in, even clinic now, every 3 months, 6 months before a checkup. Happy, dancing, loves all the team, always smiling. Mom says he doesn't stop smiling. And now being more involved in school activities, making friends like no tomorrow. He's got on his life with no burdens.
Well, this is published though. There are studies showing the impact of facial appearance and self-awareness.
Sure.
And I think we'll be sharing some of these references with our audience And you can see, and you can probably, we'll also mention it below in the comments section.
Absolutely.
But also, I understand that as a child you had orthodontics.
Yes.
So could you tell us your experience?
Yes. So, and it's funny you mentioned it also timing. So me, probably you can say I went through 3 rounds.
Okay.
So number 1, as a young kid, again, crowding. I have a narrow upper arch. So we needed to start expanding.
How old were you at the time?
That time I would say around 10, 11.
Okay.
All right. We used like a removable device. I would wear it throughout the day. It had a small like expansion screw in it. Turn it once a week to start widening the jaw to make space. Went through that for a bit, few months, close to a year. Not much space there because of the crowding. So it was decided, okay, round 2, let's do extraction-based treatment with braces. So I had 4 premolars taken out to make space, braces put on, and it's lined up my front teeth. And I know, looking at pictures, talking with my parents, they told me as a teenager, you did not like to smile. You actually, and I think that's one thing parents can see. Look at pictures. Teenagers, I would not smile in pictures. I was shy of showing my teeth because yes, I got 2 big front teeth, and if it's crowded, they're out there. So once things lined up, I got my confidence back. Was smiling. School went okay afterward, and that's it. Went off to uni, training, came back. Life was all great, and then as you know now, as we're working, we notice okay, no. Right, I've got nice front teeth, but bite function not there yet. So what to do? We're like, let's do orthodontics again. 3rd round with you guys over here. So now it's with aligners, it's with mini screws, expander, and this time we're doing the treatment to try and give me a more functional bite with less, let's say, interferences.
Okay. Well, that's good. And then you also mentioned that your treatment, I guess the 2 treatments were done as 2 distinct treatments, I believe. Yeah. So if a child was how do you feel about if a child was needed treatment at let's say the age of 7 or 8? Would that treatment continue into teens, or how do you approach dealing with this interceptive rather than early orthodontics? I like to use the word interceptive orthodontics. So how would you deal with interceptive orthodontics?
So it's like you mentioned, Dr. Hakim. So sometimes, yes, we got to start at 7, even earlier than me. 7, 8, like the patient that I see now. We started at 8 years. We, let's say, align the teeth, whether it was get them out of harm's way or try to facilitate anything that was impeding growth and development. We get things to where we want them to, and then that's when we decide, okay, time to stop, let the patient have a break, and just hold things into place and monitor growth. We don't tell the patient goodbye, that's it, they're done, walk out of the door. No, it's very important. We say them every 3 to 6 months, see how they're growing. We are humans, biology kicks in, how we're growing, how the face develops, how the teeth change. Did we lose teeth early? No, is it still being held on? And we address things as we go. And if things stay stable, then we just wait till maybe they're a teenager where we have all the other sets, and again, reassess again. Do we need to go in and do the teenager face orthodontic? Or is everything okay? So it's like you said, we cannot say early or late because growth is a process with time, and we just got to be on top of it. And when it's the time to do something, I think that's when we should go in.
It's on time, and that's why we have the reasons. That's why we establish the main reasons, because we need to have a goal. Yeah. We need to start the treatment or not start the treatment. So that's something that we also address. So the consultation, the first consultation, we have this in Brazil from the American Association. That's something that is a standard. From 7 years old, but that doesn't mean that we cannot see the patient early if there is any indication, and even see the patient, but actually just follow up. If everything is going in the right way, in a normal way, and there is no other reasons that fit into these 3 that we mentioned, we can just follow up the patient, or we have to have a very specific goal, go in, do the treatment, fix whatever needs to be fixed, and then step out and follow up the case.
I think it's very important and this is to avoid burnout.
Absolutely.
You don't want to start the child
Yes,
at this age with the baby teeth, and then it just drags on. So essentially, the interceptive orthodontics is about eliminating the justification.
Sure.
We can have children coming in with the same condition, but one child is completely oblivious to it and is fine and is happy, and the other child can be very sensitive to it. So this treatment has to be customized, and you can't take the cookie cutter approach and just treat everyone in the same way.
Yeah.
Now, moving on to our second justification, and I know you face this a lot in your main career, I guess, as a jiu-jitsu expert.
Yes.
So could you just share with us, how the impact or the necessity and why this is a justification?
Yeah, sure. First, just briefly, my case, my orthodontic case, it was exactly the one that I was talking about. I had my first consultation around 7. Everything was normal. I didn't have any concerns, any aesthetic concern. I was fine with it. And then later on, after I think I was around 14 years old, very straightforward treatment, alignment, and that's it. That's pretty much it. However, we do have, my sister actually was fitting on our second reason, which is the increased risk of trauma. Okay. So she had some procline teeth, and we do see that a lot in some kids here in Dubai that play jiu-jitsu. So that's that combined with the proclination of the teeth. We do have a very simple test that we can check. We can touch the nose and the chin if we see that the teeth are touching in a risky position, exactly like that.
That's it. I think we all can do it.
That's what we always do whenever we see, of course, a patient like that. And we can assess that. If it's needed, we can go in. Again, we are going to do the treatment. We're going to move the teeth back. We're going to put them in a position that it's not at risk. And again, once that is done and there is nothing else that is not abnormal, everything is going into the normal position, that's one of the main justifications. So we do have a lot of patients that they're doing jiu-jitsu. Once we see that and they're fighting, they don't have, if they're not wearing a sports guard or anything like that, so we can address that issue as well.
Yeah, and I think it's very important you mentioned that it's essential in contact sports.
Yeah.
Whether obviously if there's an increased risk of damage due to trauma, that has to be taken care of.
Yeah.
But even in cases that don't have the increased risk, it's very important to wear a sports guard.
Sure.
And I think this is something that we can all agree on to ensure
of course,
that this is safe.
Extra care for sure for any case.
Yeah. So not to be left out, I also had an experience with I would say interceptive orthodontics growing up. I had a sweet tooth. I lost quite a few teeth growing up, but I got into an accident, and I lost actually quite a significant amount of teeth growing up, baby teeth. And I'm blessed that my father is a prosthodontist, and that is the dental specialty that replaces teeth. So he's very good at making dentures for the elderly at the time. So he made me dentures, which is like a space maintainer.
Yeah.
So growing up
with teeth.
Yes, with teeth. So as a child, I had artificially replaced my teeth, but then when the permanent teeth came in, I never required. I didn't have any orthodontic treatment.
There you go.
And it wasn't until I got into the residency program in Colorado, and we had to practice on each other, taking photographs and taking impressions. And we had to go collect our models, and I was looking for the perfect set of teeth because I thought I had perfect teeth, and then I didn't realize I had quite a few rotations, and my teeth didn't appear to be better because it was as I aged, I guess my teeth started to move. This is age-related tooth movement, but it was kind of symmetrical. So I was under the impression that my teeth were straight, but they weren't. So once I realized, I got into Invisalign treatment at the time, and that was my experience. So I had interceptive orthodontics as a 7-year-old, and then fast forward to my 30s until I got comprehensive orthodontics to align these rotations from age-related tooth movement. So I guess now the last point, and this is open for all of us, is when it comes to the factors affecting normal growth and development. And I think this is very key. Sometimes it's a habit, like a thumb-sucking habit. But sometimes, and I think this is very important, is that teeth can be erupting in the wrong position. The canines are notorious for this. So, and we'll share some X-rays of showing teeth that are kind of growing horizontally.
Stuck in the bone.
And unfortunately, what parents often tell me is, well, isn't my child too young to start? Because they were told either all the adult teeth had to emerge or the child had to be 12. And both of those, again, are not correct. Because, like we mentioned, if there's a justification, we have to intervene.
Sure.
And if there isn't a justification, then we wait and see and we observe. And then moving on, we also have issues now with the latest guidelines from the American Academy of Pediatric Dentistry relating to the habits of mouth breathing. And obviously sleep apnea. These are very big topics that are now being mentioned. And it's very important that any parent that has a child that is suffering from these conditions to seek the right treatment. It's going to be a team effort.
Absolutely.
And we've got to have clear and distinct goals, and we've got to have measurable parameters as well.
Yes.
I think this is very important. So when it comes to interceptive orthodontics, it's all about getting the understanding why there's a justification for intervention. It's about understanding what is being measured. And it's also about what are we aiming for? What do we hope to see as a change?
Think clear goals.
Yeah, very clear goals.
And also make that clear with the parents and with the child that is going to go on treatment, because we need to time that also with the expectations and everything involving the child, which is the
and not
center
to burn
of
them out. We cannot just keep it running ongoing.
Of course, and to add to that, the treatment has to be designed so that the child can actually cope with it.
Yeah.
The last thing I would want is to burden a 7 or an 8-year-old with a treatment regime that's going to be so difficult for them to do. And then in the event it didn't achieve the desired outcome, that child is then blamed.
That's true.
Yeah.
I think this is not a good way to practice. And I think going to the right team, to the right specialist, they would make sure that any kind of intervention is going to be one that will benefit the child and not hinder the child. I think this is very important. So for all the parents out there, I think this is very important, that any kind of proposed treatment for your child has to be one that they can handle and that can achieve these measurable outcomes. And it is a team effort after all. You know, so the child is the central part of this treatment, and they have to be able to adapt to it.
Absolutely.
Yeah.
So is there anything that you do in your practice that would actually allow you to test this?
To motivate. First of all, I think it's the motivation. I think it's everything, and we as professionals, we need to offer the options, and if we do have some trials.
Yes, that's what we do.
So we can if the child or the parents, they are not sure exactly what is going to fit better because they never had any treatment and they don't know how the child will react to that. So we can give some trials and we will see how it goes, and then we can plan like a
I think
personalized
what
one.
we're referring to here, as you know, is basic example. People ask train track braces or aligners, and a lot of parents, for example, we know maybe it's more beneficial to wear aligners because of expansion, but the parents don't know if the kid will wear it. So one simple test we do is just give them an Essex retainer.
Okay.
It's the same material as an aligner, it's just not moving teeth. Tell them wear it for a week to 2 weeks and tell us how you cope. Are you able to wear it or not? Do you wear it just 8 hours, 12 hours, or 20 hours? And then we know a lot of time parents get surprised how, our kids actually managed to wear this. It's fine, then all right, let's go with aligner treatment.
Yeah.
And same, I think, with habits, as you mentioned, people with thumb sucking habit, you don't want to start treatment while a habit is still there.
Yeah.
So we try things.
The child doesn't want to.
Yeah.
It's not willing to
It's
stop.
not willing to,
There are
so we
other
just
things
try.
related, so we need to check all
so
of that.
you try simple tests, gloves, we tie socks to
Lots
talk
of
to each other.
conversation as well.
Conversation,
Of
bribe
course.
them with rewards, and then you see, sometimes they stop, great, we continue, sometimes they don't. So like
We
you
have to
said,
do the pedo a little bit of we have to do a little bit of pedo as well with the
just
children.
small tricks,
Yeah.
and then you see, and like you said, you customize it based on the patient. All right, they managed
Sure.
to stop, we can go to another step. They don't manage to stop, what else can we do?
Sure. Yeah, and I think this is very important. And in essence, I think it's been a great discussion. We could probably go on for hours.
Oh yeah.
Yeah.
I mean, this is one of my favorite lecturing topics. In fact, in coming in the fall, I've been invited to 3 different countries to lecture on this. So this is something that is very dear to me.
It's like you said, you only mentioned thumb sucking and air. We've got the cross bite,
Lots of-
shifts,
yeah.
joints. Like it can go on
We
and
can
on.
go on.
Yeah.
But of course, we want to keep this podcast to kind of within this time limit that we're hoping to aim for. So essentially, I think it's very clear that I don't believe in anything called early orthodontics. It's either on time or we observe. There is no such thing as late orthodontics. Our youngest patient is 6, and our eldest is 75 years old.
Yeah,
So there's time or age is just a number. But if there is a justification for intervention has to be done.
Yes.
But in the event there were issues related, that were specific to that to the patient where they couldn't cope. It's just we have to just reduce the risk as much as possible. And then obviously give the practice appliances and just move forward. Growth is ever continuous, and we have to make sure that we give the child the time to give them the maximum benefit. So with that, we'd like to thank you for joining us today. Please be sure to leave comments, ask questions. We're here to take care of these. And always remember, don't just smile, smile healthy.